So today's topic's on neonatal brachial palsy, plexus palsies, and shoulder dystocias. I chose this topic because I know as an obstetrician, shoulder dystocia is one of the scariest things I can see every day, and I fear for it in my future childbearing that I'm going to have a kid with a shoulder dystocia. Also, Dr. Barrow brought up in his last presentation shoulder dystocia they had where there was a brachial plexus palsy injury, and I think we kind of walk out the room and feel better. We finally get the baby out, take off our gloves, and never really follow it up and never looked at the chart and never, kind of see what the prognosis is for the infant later on. The goals and objectives today are we're going to talk about the incidence and the risk factors of the brachial plexus palsies. Also go through the anatomy of the brachial plexus, since I'm sure none of us have reviewed that, at least the OBs. To talk about the different types of injury, the evaluation, management, and prognosis of the injuries. Also then switch into look into shoulder dystocia and the incidences associated with the palsies when you have a concurrent dystocia. And then also review the maneuvers. So we'll start off with a case. For those involved, I'm sure recognize exactly who this is. It was a patient. She delivered in 2013. She's a 36-year-old G3P2. She came in at 39 weeks for labor induction secondary to elevated blood pressure. Her past medical history was only positive for obesity with a BMI of 60. She's never had any surgeries. This was her third baby. The first two were non-complicated, vaginal deliveries, full-term, biggest baby, 7 pounds, 13 ounces. No meds. She had a pretty unremarkable prenatal course when it came to most, if not all, of her visits. She passed her O'Sullivan at 126, and she had a growth scan just because we weren't able to measure her fundal height at 33 weeks, and baby was 64th percentile, so nothing so far standing out. On exam, she was 396 pounds, 5'8". Her cervix, when she was admitted, was 1 thick and high. Just to briefly go through the labor events, just to kind of see how everything went out. She came in and got a Foley bulb at 10 o'clock that night, or 10 o'clock that night. Then she came out about 2 hours later. She got Cytotec placed, and then around 9 a.m. they really broke her water, started some Pitocin, and got things going. And then by 11:50, she was lip rim with, only thing that really stands out here is baby was at -1 station, which I know is kind of difficult to assess with a patient that's 400 pounds, but yeah. So this was the residence note. Patient had a shoulder dystocia that lasted 8 minutes. Staff arrived at 1 minute after she had already done gentle traction, McRoberts, and suprapubic pressure. Staff took over in about 2 minutes. Anterior shoulder was the right shoulder. Cord gases were sent. Baby was sent to the NICU, and she had a 2nd-degree vaginal laceration. This was staff's note. She entered the room. Baby was obviously stuck and in distress. She talks about multiple nurses trying to pull the patient's leg back, but was having a lot of difficulty because of her size. She attempted to pull the baby she did some gentle traction, couldn't get the baby out. Then she tried to deliver the posterior shoulder. However, due to the patient's soft tissue dystocia, that didn't happen. She then tried the corkscrew maneuver with no success. She then cut an episiotomy, tried the posterior shoulder again. The nurses were still trying to do McRoberts at this time and give suprapubic. She then called for backup faculty, which I happened to be on the other side in clinic and see Dr. Groom running out of clinic. And then she tried to push the baby's head back in, still couldn't do that either. And then she eventually tried doing a posterior shoulder again and got, I already said that. She tried to rotate the baby's shoulders again, and finally baby came out. So this is the infant. He came out with APGARs of 0, 4, and 5. For resuscitative efforts, they did suctioning. They ended up having to intubate the baby. Chest compressions, dose of epinephrine was given. Baby weighed 9 pounds, 1.9 ounces, which was 92nd percentile for the gestational age. Core gases were sent. pH was pretty good, 7.2. The note by the ped says that there was spontaneous movement of the left arm, but the right arm was flaccid with depressed grasp reflex. Patient went to the NICU, ended up self-extubating itself, and then they noticed significant respiratory distress, and so the infant was put on vapotherm. While an inpatient neurology was consulted, they showed that the baby had a shoulder that was adducted, medially rotated, and pronated. The reflexes were diminished in the biceps and the brachioradialis. The baby did have movement of its distal digits in his hand. There was no evidence of Horner syndrome. Also, they at that point recommended that they just start physical therapy daily, do supportive management, doing passive range of motion with the baby's arm, and to consult neurosurgery to see what their thoughts were about doing possible surgery. Then
Horner syndrome is not associated with brachial plexus injury. Those are completely separate. But anyway, you can go on.
Okay.
I'll explain you that.
Okay. Also, there was a notice that since the baby was having significant respiratory distress, there was an x-ray done that showed possible diaphragmatic paralysis. Well, it did have that. And so surgery was consulted and said they would consider plication of diaphragm if the baby didn't improve at all, which it did. So neonatal brachial plexus palsy, usually it's pretty obvious at birth. They have a weak or paralyzed upper extremity. The incidence is about 1.5 per 1,000 vaginal births, and it's also seen with cesarean sections, about 0.17 per 1,000. There's several risk factors. Fetal malposition, also with labor induction, labor abnormalities like a stalled out labor curve, operative vaginal delivery, breech delivery, macrosomia, of course shoulder dystocia, and then also any Müllerian abnormalities of the uterus or big fibroids that are obstructive. So causation. I know a lot of people, or at least in the past, it was always thought that this was just a obstetrical injury and we were to blame and that was it. However, they've noticed that even with cesarean sections with patients who weren't in labor, or even babies who came out with no associated shoulder dystocia, and or even their posterior arm was the one that was injured. So they decided that there's also endogenous forces. There's uterine contractions that can cause some problems with the arm. Also maternal pushing efforts, it increases the pressure and cause the baby to be lodged up against something. Fetal positioning. And then there is exogenous. There's clinician applied forces, especially applying force against the shoulder's fixed against something and you're trying to pull the shoulder past it. So of course stretch can be caused, and then shoulder dystocia is one of all the risk factors. It's the main one that is definitely a risk factor that's there. So the brachial plexus, I know I haven't looked at this since med school at least, or at least STEP or something, but it connects the spinal nerves, so there are terminal branches in the upper extremity. There's 5 zones. There's the roots, then there's the trunks, divisions, cords, and terminal branches, which this is a picture, I think from like Netters or something. So you can see these are the roots. They go down and break into different trunks, the upper, middle, and lower trunk, which go into divisions right here, anterior and posterior divisions on each one, which then form to get lateral cords. And then these cords go down and branch out into the different nerves in the upper extremity. So in any of these, you can kind of see by this picture if there's an injury, different parts of the roots, of course it'll affect different parts of the nerves on here, and that's how you can kind of pinpoint where the injury is. It's just a different picture. It shows the relationship of the clavicle with these nerves. So brachial plexus injuries, the injury is usually after this initial event or whatever event has occurred. They have a compression of the nerve by hemorrhage or just edema within the nerve sheath. Occasionally you can have where the nerves will actually tear or they'll avulse completely from the spinal cord. And then basically the mildest injuries would involve only C5 and C6. So it makes sense in this last picture, if you're going to pull, traction on the baby's neck, 5 would go first and start getting injured, then 6, then 7, it would go in, likely in a sequence, except with breech delivery where the arm may come out. Then that kind of starts and it can give a Klumpke's, which we'll get to, just injuring T1 and C8. So the classifications, usually there are a bunch of different classifications, but the one that's most used is just according to where the palsy is or what nerves are injured. So the upper plexus palsy, also called Irv's or Duchenne's, involves the C5 and the C6 root from the spinal cord. It's the most common type. There's about of all the injuries, it's about 50%. You get weakness in the deltoid, infraspinatus, the biceps, which leaves the arm basically the opposite of the action of the muscles. So the arm is internally rotated, it's adducted, the forearm is usually extended, and then in this type of lesion with not involving C7, you'll have hand and wrist movement that's preserved. When then you start getting into where the C7's involved, which is about 35% of these injuries, the flexion, you'll get flexion of the wrists and the fingers, and they'll get that classic waiter's tip posture you can see in the infant down there. This is a picture, shows the same thing. It shows the type of posture of the arm. Also, because of some type of which we'll go through later with Horner syndrome, you can have injuries just due to the relationship of the sympathetic ganglion that can go and cause Horner syndrome with ptosis. You can have contraction or of the eye, what's it called? Not dilation, constriction of the pupil. There we go. So, then we'll go into the lower plexus palsies, like Klumpke's. Klumpke's is kind of a rare one because you're getting just injury of the C8 and the T1. So you'll have a flaccid hand. The shoulder and the elbow function are intact. And then with the total, that's just a injury to the entire plexus. You get C5, C6, 7, 8, and T1. You'll just have complete paralysis. And sometimes you can have Horner syndrome. So other injuries that are kind of common along with it, you can have clavicle fractures, which may be related to the shoulder dystocia itself. You can have a humerus fracture. Later on, you can start getting subluxation of joints just due to the contractures of muscles, or you can have spinal cord injury with some type of trauma. Then you can also have phrenic nerve involvement. That's C3, 4, and 5. Keeps the diaphragm alive. So C5, you injure that, you may have some phrenic nerve involvement and paralysis of the diaphragm. So evaluation. Of course, the main thing is you'll see the baby has a paralysis of its arm. It's not moving. You'll do a moral reflex. Baby won't do the normal draw out, then draw back in, or may just do it with one arm. So the things you want to do is get a complete history. You want to know family history. Is there any neuromuscular or any type of family things that run in the family? You want to know maternal history. Does she have diabetes? Is she obese? Does she have also any of the risk factors associated with the brachial plexus palsies? Also the perinatal history. The patient we've already talked about is pretty obvious, I think, where the injury came. There was a 8-minute dystocia. So you want to know all the things about the delivery. Physical exam, of course, a good neuro exam. Doing a sensory, reflexes, motor, do passive range of motion. It kind of can give you some clues. If you have a arm that doesn't have all the passive range of motion, well, it kind of says, okay, well, maybe something happened in utero. This is not something new. If there's any hemiparesis or maybe lower extremity involvement, you're looking at something more maybe global, more CNS related. You can have, again, for the patient, which actually we had the diaphragmatic paralysis, you'll see asymmetric chest cavity expansion, problems with baby getting the adequate oxygenation. And then you can look at you want to also feel for any like bony changes, any obvious fractures, look for bruising, and then maybe do some radiographs of the arm, of the shoulder, of the chest, looking for any type of fractures. Also, they talk about electromyography and nerve conduction studies. They say there's no real recommendation on it, but you can kind of get a clue on if it comes out and there's some abnormalities on these studies right away. Maybe it suggests something a little bit older, or you can compare first day out to a few days later. If there's some new insults, then it kind of could say maybe it was more birth related, or also you can use it for follow-up. You can see if there's any improvement. Neuroimaging, you can kind of look into more of like new nerve avulsion, look for more serious things, look for any type of meningocele that can occur from trauma, or any type of post-traumatic neuroma or something. So this is the sniff test. This was actually the, Dr. Barrow, how do I get it to play? I put it in here.
That's Jenny.
It had a link on it. Oh, there it goes. Okay. So this is the X-ray showed an abnormal of the diaphragm. So I went ahead and I didn't do it. Sorry. They did a sniff test, which is it's not lit up. Must have ran out of power. Can you hear it? No. Thank you. Talk loud, sisters. So the sniff test is just a fluoro. They go and take just fluoro pictures of the baby breathing. And this one, well, it flipped the whole picture. Anyways, the diaphragm wouldn't move on the right side. It was moving on the left side in and out for inspiration, expiration. Yeah, if you do like that. So in so management. One of the main things they talk about is early physical therapy, of course, doing the range of motion, keeping from trying to at least improve from it having any contractures from the muscles not working anymore. And you want to kind of start really early. Within the first week of life, this baby got it very fast in the NICU. Also, their surgery they don't really have a hard recommendation on it, but they say at age 3 to 9 months, if there's really no significant improvement right off the bat, then you want to kind of consider looking into at least having surgery or send it to someone who can make that decision, or referral to specialty centers. They offered to go to Dallas, I think New Orleans. They mentioned just different places who are used to having these type of injuries, or at least places that will have teams of all different types of specialties together to look at these injuries. Again, there's no standard guidelines, but some of the tests that they do use to see, to kind of quantify the function of the improvement, they'll say a cookie test. If the infant can't pick up a cookie and put it in his mouth by 9 months of age, you're kind of concerned about that. Also a towel test, pulling a towel off their face by 6 months of age. And then if there's completely no recovery of a biceps function after 3 months, you want to kind of consider sending to someone else. Prognosis. Most cases, babies recover really fast. 1 to 3 months, they'll start showing significant improvement, if not all. 80 to 90% resolved by the first year. And then they kind of, this is kind of seems obvious, but the faster they start showing improvement, the better prognosis, and if it's not, stalled out. So it's difficult kind of to assess. They talk about real numbers on improvement, just because either infants will be lost to follow-up, or they may not notice the Erb's palsy right off the bat, and so baby never went to see a pediatrician, or they just spontaneously recover so fast it was never recognized. This guy Gilbert did a bunch of studies on brachial plexus injuries, also like on the prognosis, follow-up, surgery, and everything, and they like to classify according to groups, which is just basically according to which nerve groups were affected. Patients with just the C5, C6 tend to do really well, recover 90% full spontaneous recovery, and it's usually before the 2 months of age, so it's very fast. And then once you start getting the C7 involvement, it's a little bit less of a full recovery. They kind of tend to start recovering a little bit later. 3 to 6 months takes a little bit longer, and then you start getting into the lower nerves, the C8, T1. It's just, the prognosis is, positive prognosis decreases. So a little bit more back on the infant. He was delivered on the 31st and stayed till the 25th. They discharged with the referral to Shriners. I don't know if students know Shriners is like a kind of an ortho-related hospital next door. Neurology follow-up at 3 months said the arm was still internally rotated and extended, good movement of the fingers, able to lift the arm, but it was lifted at an extended position. The biceps reflex was still diminished. They did say, though, that the arm does appear improved, but they would like to send a referral to pediatric neurosurgery to see what they thought about surgery. At 4 months, started having some flexion of the right elbow and the right wrist. And at 5 months, there was a pretty significant improvement on the abduction rotation and elbow flexion. 7 months, baby went to orthopedics department here, and there says return of elbow flexion. Basically, it says, and you can see in the impression, patient with returning function of all nerves. It did have posterior subluxation on ultrasound. And they just suggested, again, doing passive shoulder stretching several times a day and using a splint at night just to kind of help with contractures. 10 months neurosurgery. Mom says, okay, the improvement stalled. It was doing well. Now nothing's happening. The neurosurgery department said if there's no more improvement, then they should probably get referred, and then no follow-up was ever scheduled. Neurology saw the baby at 14 months and says, okay, this is a really slow recovery. We recommend surgery as well. And the baby missed the follow-up there, so it kind of just stopped all visits. It is still visiting Shriners, they say in every note, but just kind of stalled out. So one thing they discussed to be aware of, especially us seeing the mom after the postpartum visit, or for the postpartum visit, to think about the injuries to these babies. The moms would probably feel pretty bad about it, especially if they realize, their diabetes could have contributed to it, or, I'm sure every mom likes to take blame for their child's, deficits. So you should really keep that in mind and talk to her about depression or feeling, like it was her fault. Also, they said that children with plexus palsies will have, compared to controls, they have a higher incidence of withdrawal, depression, anxiety, and just social problems with aggressive behavior. So keep that in mind. Prevention. The problem with prevention is risk factors aren't really good at predicting. 80% of the cases of injuries have actually no risk factors present at all. The only real established risk factor is shoulder dystocia. So ACOG put out a big task force on actual neonatal brachial plexus palsies. And they kind of say, okay, well, we can't really predict it. We don't really know. You can't really say, okay, this baby's going to have this mom's going to have dystocia. But they just say, let's keep in mind a couple things that could alter our management. Suspected fetal macrosomia, any babies in diabetic mothers who are greater than 5,000 grams, you may want to consider an elective C-section or at least offering it. And also, did I say diabetic mothers is 4,500 and non-diabetic mothers is 5,000 grams. Also, if they have a prior shoulder dystocia, it's really important, students and even for us, to ask how is the delivery of your last baby? Was there any complications, any forceps, any vacuum? Was there any problem where the baby got stuck? Ask them. I doubt they'll know what a shoulder dystocia is. So you just need to ask and say, okay, well, how was the baby at birth? Did it have any problems? And they could probably say, oh, its arm didn't work. And so you kind of get a clue on what really happened. Also, mid-pelvic operative vaginal delivery with infant weight of greater than 4,000. If we're expecting a macrosomic baby or at least a large baby, you might want to consider if the baby's not coming down, there's a reason. So brachial plexus that are associated with shoulder dystocia, it complicates about 2.3 to 16% of shoulder dystocias. Most cases are, again, still transient. Babies usually recover really well. The incidence of persistent injuries is about 0.5 to 1.6%. And so we'll switch a little bit into shoulder dystocia. So shoulder dystocia is basically any delivery that requires an additional obstetrical maneuvers after just simple gentle downward traction on the fetus's head. If it requires anything other than the traction to deliver the shoulders, it's considered dystocia. However, there are some other places or other criteria that say, okay, if it's a delivery of the head followed by at least 60 seconds before the delivery of the body, then it should be called a shoulder dystocia, which kind of causes a problem with calculating the incidence of it because, I know I went through a couple of charts that I knew had a shoulder dystocia, and several of them are 20 seconds long or 30 seconds long, so a lot of those wouldn't be counted as shoulder dystocias. So it occurs, again, when the anterior fetal shoulder hits the pubic symphysis. Less commonly, it can happen with the posterior shoulder getting lodged against the sacral promontory. Again, the wide variation in reported incidence is likely due to the differing of the definitions, also just documentation itself. Why document a shoulder dystocia if you weren't really sure if it was? It might have just been a problem getting the baby out for whatever reason. So it's kind of got a wide variation from 0.6 to 1.4%. That's from the ACOG practice bulletin. Morbidity. Maternal, of course, there's an increased risk of postpartum hemorrhage, about 11%. That can be from just apnea itself or from having a big perineal laceration. 3rd or 4th degree perineal lacerations, there's about a 3.8% risk. With the baby, of course, there's asphyxia. They showed that a lot of deliveries, if the head to the body delivery time was greater than 4 minutes, that's when you started having a lot more problems with hypoxic injury and problems with because of not getting oxygen for that long. Also trauma, you can get, of course, the brachial plexus injury, and you can have fractures of the humerus and the clavicle. Risk factors for shoulder dystocia, again, fetal macrosomia, diabetes, diabetic infants, I think it's like a 2 or 4-fold risk higher to have a shoulder dystocia. You can have prolonged second stage of labor. Kind of gives you some thoughts about, well, why are we stalling out and the baby's complete? Why is the baby's not coming down? Other risk factors that aren't as strongly associated but are definitely suggested a lot are a history of macrosomia, where you're more likely to have another baby that's macrosomic even though it wasn't diagnosed or suspected. You can have it in postpartum pregnancies, multiparity, and then operative vaginal delivery from mid-pelvis. So again, previous shoulder dystocia, the risk of recurrence is about 1 to 13%. This is also, they talk about, kind of hard to quantify, because if I had delivered a baby that had a really terrible brachial plexus palsy, I would probably offer mom, hey, maybe we should try and do a C-section this time. So they're not really getting to have that second delivery and kind of quantifying if it happens or not. Also, counseling, when this goes into account, you want to talk about different things. You want to figure out, okay, well, what's the estimated fetal weight of this baby? You want to know what gestational age they're at. If they had a shoulder dystocia in their first pregnancy and this one's a PPROM at 34 weeks, well, baby's probably not as big. Also, maternal glucose intolerance, the diabetes status is really important. Also, if there was a previous shoulder dystocia, you want to know, like, was the baby injured? Then that would kind of make if they didn't know they had a shoulder dystocia, we just have it in our charts documented, and baby didn't have any significant injury, then maybe they're more likely to opt for a vaginal delivery. So ACOG even says afterwards, if after informed consent and you really discuss it with the mom, either mode is appropriate. You don't need to force one way or the other. And one thing they do discuss in that practice bulletin as well is, even though, since ultrasound is not very accurate at 40 weeks, you can talk to mom and say, okay, well, how big was your last baby? 7 pounds. Well, how big does this baby feel? And they can actually give a lot of information into how big their baby is. So again, fetal macrosomia, the shoulder dystocia rates in babies greater than 4,500 grams goes up to 9.2 to 24%. So that's a pretty big increase. And also, when they have diabetes and it's greater than 4,500, they have a dystocia rate of 20 to 50%. So that's pretty high. And that's why they kind of give those recommendations for us to really think about these deliveries and how big the baby are and if mom has diabetes. The risk of brachial palsy injury among infants delivered vaginally increases to 80 to 21-fold when the birth weight exceeds 4,500. So it really, really increases once babies get bigger. This was just a graph from the practice bulletin. It shows birth weight at the bottom and shoulder dystocia incidence. And the top 2 lines are just moms with diabetes. Look how big of a difference it makes in shoulder dystocia at the same weight. So that's why there's a difference in the grams.
These are assisted just means and forceps are done.
Mm-hmm, yeah. So ACOG, again, their recommendation straight from the practice bulletin is planned cesarean delivery to prevent shoulder dystocia may be considered for suspected fetal macrosomia in fetal weight exceeding 5,000 grams in women without diabetes and 4,500 if they do have diabetes. And I've always thought about it forever, like how does that, doesn't make any sense. Like, what is the difference? And it's just because we'll see a lot of times diabetic moms will have a big AC, so they'll have a big shoulders, and that's why it accounts for the difference in the weight. So the management. I know a lot of studies say that while shoulder dystocia simulations don't actually improve outcomes, it improves just the way things flow. It actually does decrease the head to body time. So we actually do a simulation here, which is great. Thanks, Dr. Quinn. The goal of shoulder dystocia, of course, is we're just get the baby out. You want to reduce the head to body delivery time. At the same time, you want to balance not being really just aggressive and breaking arms if you don't have to. So once noticed, your main thing to do is to stop and say, okay, everybody, we have a dystocia, let's prepare. I need some nurses to do what you go through the maneuvers. I need y'all to, mom, stop pushing. You don't want mom to push the baby's shoulder up against the pubic symphysis. You want to call for help. You want to get your upper level. You want to get staff involved. And you want to notify peds. Peds needs to be there to see the baby after it's born, NICU, whichever is appropriate. So again, since we talk about you can't really just to predict the shoulder dystocia that well or brachial plexus injuries, you just really want to be prepared. So we'll go through the maneuvers. This is just McRoberts. You want the hips flexed sharply, both of them, and then you want to also use suprapubic pressure to try and free that anterior shoulder right there from below the pubic symphysis. Then you want to try, some studies even say delivery of the posterior arm should kind of be your next maneuver after suprapubic because it was really effective in McRoberts. You insert the hand right here along the humerus. You want to splint the arm across and then sweep the elbow, keeping it flexed, sweep it out right here, and then that way it kind of reduces the diameter right here of the shoulders. And then you have the Woods corkscrew maneuver where your hand's placed behind the posterior shoulder and you rotate the shoulder 180 degrees in a corkscrew manner to try and get this arm out of this plane right here and get it more of an maybe this way or a different way. Rubens is kind of similar. You want to get whatever shoulder you can get and push it towards the anterior chest wall and basically, reduce the diameter like that. And then episiotomy. Episiotomy we talk about is one of the maneuvers. It's really not a maneuver as much as it helps you with the other maneuvers. If there's any shoulder dystocia like the patient we had, difficult trying to get through the soft tissue, you cut an episiotomy that may help get your hand in to deliver the posterior arm. And there's no change that's what they talk about in studies, there's no change in brachial plexus injury in groups where it was not performed. It's just kind of there to kind of help you. Last ditch efforts. There's more maneuvers after that when you're really desperate. You can fracture the clavicle, just put a lot of pressure onto it. You can do Zavanelli's where you return the head back into the uterus. You can try doing terbutaline to relax the uterus if you can't get it. I've never can imagine it working, but you just basically flex the head and slowly push it back in. The goal is just to roll for a C-section or do the C-section bedside. Symphysiotomy, basically cut through the pubic symphysis to widen it. Ugh. So, documentation they say is pretty important. In a shoulder dystocia, you again want to know the time of the delivery of the head and the time for baby. You want to know, peds definitely wants to know how long was this baby stuck for. Position of the fetal head, I'm guilty for this. If I don't remember, I just say LOA, but it makes a difference. Baby comes out, was LOA and it's got a left shoulder palsy when you're kind of confused as to how it happened. Right shoulder palsy, it makes more sense because the right shoulder stuck. You want to know the maneuvers performed and their timing and their sequence. You want to talk about the perineal exam afterwards, how bad was the laceration, blood loss, of course. You want to know the staff who was there, was peds there, APGARs, the condition of the baby. You want to say no palsy obvious or no obvious fractures. It's a good idea to send your umbilical cord to get cord gases. And really just comment on how the baby was doing. I know peds does a better job of that because we just hand it off. That's it. Those are references.